welcome back to our Vascular Ultrasound Master Class. My name is Zsolt Garami. I'm the Medical Director for the Vascular Ultrasound Lab, and my guest is Stephen To, my lead vascular sonographer. We are going to give you a few cases of interpretation masterclass, and these are again not our normal studies. Hopefully we'll learn how to interpret those difficult vascular cases. If you would like to ask any questions, please text DeBakey to the number 37607, or on the web you can go to pollev.com and enter DeBakey. Also, I would like to thank everybody joining us last month on our vascular masterclass. We had about 800 live viewers and about 1,200 by next day viewed or reviewed our recording. So we would like to really thank you, and we'll see you next year. I'm so sorry that we had to skip the hands-on session, but I think with this virtual format we can show you more cases next time. And also, if you're interested in any of our monthly Vascular Ultrasound Masterclass, please visit the LiveStream channel, DeBakey, and in the past recorded lectures you're able to see our cases and recorded videos. Also, with a big request, we may put our Vascular Ultrasound Masterclass on demand back online, because we receive lots of requests that they would like to review our protocol lectures. I don't know how many of you familiar with Kahoot, but everybody loved the game. And what I'm proposing that depends on how many people are live and how many people would like to play with us again today. This is the game pin you need to enter, and probably after the first case we'll see how many people online and if we can play another game on Kahoot. These are again images that you need to interpret and ask, just answer from 4 different possible answers. If we don't have enough audience live, we're going to review the answers from October. Also, today, as usual, we just would like to talk about waveforms. And the waveforms will be a story of these cases, what we are going to discuss today. And I just would like to reference you one of my favorite articles by Dr. Alexandrov. In his book, this is one, and also it's published also in the Journal of Neuroimaging. And this just shows you the waveform, that how from the aorta to the common carotid, to the bulb, to the IC, what are the different waveforms you're going to see. And I think one of my favorite sentences all the time is, watch out for your systolic upstroke. If you do not see your systolic upstroke, definitely you need to go back more proximal, because you are missing a lesion. So these are the waveforms I want you to memorize. Maybe create a poster, put it on your on the wall or on your screen, but these are the normal waveforms, and when you do not see those normal waveforms, just question in your head, did I miss a stenosis? Let's go more proximal and let's rescan. So without any further ado, I would like to show you our first case, which is a 66-year-old lady with a right-sided weakness, facial droop aphasia, and left MCA infarct within a month. And we performed this carotid ultrasound this weekend. So these are really fresh cases. We are not really digging out really old cases, but we wanted to show you something that what we've done this weekend. Stephen?
Hey, so right now, let's see. So we're going to go through these images and slides and make sure that, or give you my perspective of what we're looking at from a sonographer's viewpoint. Are we live? Okay. Mm-hmm. So here we are in transverse. If you can take a look here. Pretty standard look on mine.
Are you able to see it? Yeah, I see
I
it
see,
on
yeah.
this one.
All right, so here's a color sweep. So following the 2D sweep, we're gonna do in color. We're looking for any color aliasing here that could maybe give us a idea that if there's stenosis or not. In long 2D, proximal. Colorful Doppler. So immediately we are starting to see some blunting in the systole. Mid-common carotid, and if you look closely, you could still see that the intimal lining here is still very smooth. Another Doppler signal, which is still showing this monophasic waveform.
So definitely, this is where we just said the systolic upstroke is not there.
It's not there, and it's just getting worse as you keep going distal. ECA, we are seeing some focal aliasing here. So looking at this, we can already tell that the inflow velocity here is actually quite low, and as soon as you hit this point, it's elevated. ICA, so we can see that it's very smooth. The scale control is actually quite good. We might see just a hair of elevated velocities in the center of the bulb, but as it's being walked through, the velocities change from 35 to 44, not a significant amount, but this waveform, wow.
Can you go back and show us the ECA one more time? Because
Sure.
I think the ECA with that reversal really showed that trying to be as high resistance as possible, and for some reason your ICA is really stopped at the 0 line. So even a low resistance part kind of telling you that where is the systole and where is the end of diastole.
Yeah.
But definitely the two waveforms telling you both of them going up north. But that really, end of the diastole, you see a little bit of flow reversal on the ECA.
Right. And the shape is similar to the ICA. The only difference is that this is all unidirectional, and the ECA is definitely
Beautiful point. So it's telling you that both of them originating from the common, and both of them is giving you that this is definitely you're not dealing with your proximal ICA stenosis alone, but again, you need to think more proximal for that.
Yeah, I'm already thinking there's something that's going on more proximally.
Yep.
Scale's not changing, don't need to. Colorful's still good. Here we are, look at this. So we're at the color flow sweep of the vertebral artery to the common carotid artery. We have a pulsatile blue signal that is moving away from the beam, so moving in this general direction here, so from left to right. And you can see that the difference in color from the vertebral artery to the common carotid is opposing as well. So blue and red, so definitely that solidifies that they're going in completely opposite directions. Incinerating the vertebral artery, we're getting a high resistant retrograde signal. High resistant, and also that monophasic or weird monophasic signal too, right? There it is. Another look. So delayed systole, subclavian, minimal flow. Look at the velocity here, 27.6 on the systole, and of course 0 in diastole. But man, that's slow and it's monophasic. All right, going over to the left, what are we gonna see? Oh, excuse me, sorry. All right, seeing some aliasing in the bulb to the ICA, I believe. So we have the medial side, lateral side. Lateral side's typically your ICA. And from the get-go, common carotid proximal segment, we are seeing elevated velocities and turbulence. And diastole is 47 centimeters a second. So with this waveform already, what do you think, Dr. Garami?
So you can tell the difference between, again, your right and left side, but you have some bruit on the top of your increased velocity.
Yes.
So I would say that this is a beautiful compensatory flow. If you show me a mid part, also maybe elevated.
All right, let's see. smooth intimal linings
Yeah,
here.
so
Yeah,
definitely
smooth.
not, the velocity is not increased because you have a stenosis. So this is probably a nice hyperemic compensator flow.
Mhm. Yeah, absolutely. All right. Distal. Waveform is constantly kind of changing, getting, would you say, a healthier
Well,
waveform?
yeah,
would you say?
lower resistances, I guess.
You're seeing more characteristics on it.
Hmm.
Okay. A little dark. Let's see if we can increase the brightness on this using DigiView. That helps, right? Oh, ooh.
That's really
A little
dark.
dark, yeah.
Yeah.
There you go. So I'm not really appreciating any black. You can see the intimal linings here and the trajectory of the vessel here. Okay. And of course, Doppler signals, everything seems to be really smooth. Color looks smooth. Definitely seeing some calcified plaque in the bulb and aliasing.
Hmm.
If I had to critique, maybe increase the scale to compensate for the increased velocities from the compensatory flow so that you can maybe single out some stenosis in the bulb. Otherwise, everything here seems to be stenotic with this scale.
This is so funny. This is your own scan and you're still critiquing it.
Oh,
Oh my God.
it's true. I
Can
make
you go
mistakes.
back to the ECA? No, never. Go back to the ECA just to show how low resistance in my first look at that waveform.
Yeah.
So I think this is where maybe even the ECA is playing a collateral flow pattern
Sure.
because that right side definitely needs help. But this is stunningly definitely not the high resistance ECA,
Yeah.
what usually we see with a normal scan.
And it does look like there's a branch right here too, on the
Mhm.
on the deeper side here.
Yep.
So yeah, we're definitely in the ECA, but there's internalization already happening.
Mm-hmm. Cool.
Okay. Elevated velocities, 84 end diastole. So 267 over 87. Let's look at that again. Nice positioning of the.
Yeah, beautiful picture. So this is where I think you just need to point out that you, driven by that aliasing on the color Doppler where you're positioning your probe, and if I critique, I will bring up the zero line a little bit more.
Mm-hmm.
So you're not doing the aliasing on the spectrum on that, so you will have that wraparound artifact a little bit.
Right.
But otherwise, I think your scale is beautiful. Your positioning and angle corrections. Beautiful picture, sir.
Thank you. Okay, some turbulence. You can see the turbulence at the peaks here. But the velocities are continuing to drop now. Angle correction here. And a distal sweep. So sometimes when I'm having trouble with getting all the vessel in one plane, then I have to do a sweep. 109 over 43. And let's look at that again. Compared to the inflow at the proximal segment of the internal carotid artery, I'm not seeing too much of a change in the waveform here. So less likely that there is a high-grade stenosis. Vertebral artery sweep, showing that the direction of flow is the same.
Mm-hmm.
Red and red. Blunted, but 53 over 17 in comparison to the other one, which was retrograde and high resistant. Elevated velocities, 430, way over our parameters for stenosis, which is the threshold is 200 peak systole. As we move diastole, immediately it's dropped off, and you definitely see the turbulence there. A couple more. And what we do in our protocol for carotids, I think is quite unique, is that we also include volume flow in our positive cases. So in times when we have high-grade high-grade stenosis, on both sides we will do a volume flow and see if there is a difference or not. So, Dr. Garami, what's a fair amount of volume flow which is significant to you?
I think we pulled some reference papers, and 400 to 800 would be a normal range.
Mm-hmm.
But if you have a chop of half, That's a significant difference. So this is why we are pulling up the volume flow, that if you have, for example, a bilateral 70% stenosis, which side you want to attack first with intervention surgery or stenting.
Right.
So this way, the volume flow tells you which is the side of the recipient of the collateral flow. And in this case, I think it was definitely obvious. So the left side was
640 here.
640.
640,
okay.
yeah. And we're taking a few more. Everything seems to be pretty consistent or within range. And on the right side, it's
And this
just
is the right
82.
side, which is only 80, 88.
Yeah, 82.
Wow.
That's insane.
So I think that's the two pictures tells you the difference. And again, what I think is really interesting, that because if I would notice the scale, because your scale is so decreased in the right common carotid, suddenly wouldn't see the difference between the two waveforms. But the volume flow is kind of stunning difference. So let's, I think that's the end of, and I think there's one more picture, but let's go through the interpretation. I think I would love to see the easy part. Definitely start with the last one, because there was more than 50% left subclavian stenosis. We would agree on that one. And the second easy one was the 50 to 69% left ICA disease.
Sure.
Because the ratio was over 2. We had the peak systole over 236, and the endostolic was 87. So all the three numbers in our grading system has to be more than 230 and more than 4 for a 70% stenosis. So because all the three numbers, actually 2, was the endostolic also did not reach the 100, we're going to call it the 50 to 69% stenosis.
I see.
The most difficult interpretation, I think, it's on the right side, because it cannot be a coincidence that your right subclavian has the minimal flow, your right vertebral is reversed. So I think the retrograde right vertebral artery, that's the other easy interpretation. And in your report, you beautifully did bilateral blood pressure, and I think that's the very important point, that in our protocol and on our report, we're going to display the bilateral blood pressure. The right side was 82, while the left side was 159. So definitely in that 77 mercury millimeter difference confirms a severe right-sided disease and the subclavian. But when we are coupling it together with the abnormal waveform in the right common, we definitely think this is a really severe innominate stenosis. And I think we just recommend imaging correlation, basically. So, well, thank you for this beautiful case on the weekend. Let's close this one. I think the introduction, I kind of mixed the two cases together. I'm very sorry. So this was a 62-year-old patient and was a pre-op evaluation before a valve surgery. The introduction I did is basically for the second case. So the second case is the one with the left MCA infarct. And please show us the 115.
You got it.
So this is again the 66-year-old lady with the left MCA infarct.
Okay, let's roll through. All right, so transverse carotid. We're singling out the bulb here. So far, it doesn't look like it has a significant amount of plaque, if any. Just at the bifurcation, having a tough time getting those colors in. So repeat, good, much better. So the sonographer changed the angle. You're on somewhat of a tortuous common carotid. All right, 81,
Yeah, let's critique it.
Oh, yeah, sure. Yeah.
If you did critique your own work, let's critique someone else's work,
Fair.
please.
Sure.
I think you're too generous not to critique. Again, this is not your study, but I ask you nicely because you have a special connection to this case as well.
Yes.
So can you tell us, so how would you do a little bit better on that waveform?
So there's
angle correction for sure.
Right. Angle correction, you probably could make it a little bit more parallel this way. In turn, what happens whenever you squeeze the angle is that your velocities are going to drop because the scale is going to move the 100 up this way. So it's going to drop your velocities. Another thing that you could do, if you want to really maintain a 60-degree angle, is that you could point your Doppler beam straight down this way and keep your angle 60 here. Of course, with everything, there's always a, how you say it? It's a double-edged sword, right?
Mm-hmm.
So when you do that, you're going to get elevated velocities because of the curve of the vessel here. So you really just, at this point, you have to pick your poison. Yeah. We're seeing some soft plaque right here in the mid-segment. So using chroma, we're showing it in a different way, slightly different way. Color scale is perfect here. We're seeing slightly lower velocities here in comparison to the center here where there's some heat, is like what I like to call it. A couple more sweeps. 87 peak systole. 75 on the exit of the narrow area, supposedly, so it's not a huge change. ECA, some focal hard plaque at the ostium. In this particular case, I probably would have maybe chosen a segment that's closer to the plaque. So maybe changing the beam direction over here and having the angle sweep upward.
But this is again, go
ahead.
back.
Yeah,
Look
yeah,
at
sure.
how low resistance the ECA signal again. I
Yeah.
guess today we're going to call it a low resistance ECA signal day. And if you can go back just to the distal CCA signal, so
Sure.
systolic upstroke started to delay. And I think this is where we call it a little bit dampened signal for sure. And I think for me it's stunning that you picked, the sonographer picked the ECA. And after the ECA, definitely we'll see the ICA signal, but just I want you guys to remember these three signals. So this distal CCA signal shows the ECA and
So-
shows the ICA.
I see, here we go.
Wow.
Whoa.
So this is where you said that you want to do more proximal on ECA and said, hey, can we go back and rescan this bulb because I thought that was a little bit more, we might miss something why the systolic upstroke destroyed
Right.
and why you have a barely pulsatile ICA signal. So despite it, I see the grayscale, but I'm missing the color box. I'm also missing more proximal measurement throughout that area where you really see the plaque. So I think that was a beautiful waveform after the plaque, but I really wanted to see some measurement in the proximal IC area.
Right, when you see plaque like that, you really should try to attack the area where a majority of the plaque is. Yeah. But yeah, seeing the obliteration of the waveform completely changed from the distal CCA and a fair amount, of difference in the ECA. Yeah, you would be suspicious of a high-grade stenosis at that particular area.
Yep.
So smooth intimal lining on the mid ICA throughout. But wow, it's just getting worse.
When I saw that, I was almost questioning, is this a venous signal? So
yeah.
for a moment, I really didn't want to believe that this could be an ICA waveform. So one of my favorite, look at the different pulse waveforms that are these equals, or is there any variation? Is this really venous? But first, again, when you look at the direction, the directions goes to the brain.
That's right.
Here's your low resistance pattern. So definitely, I was just totally surprised. It's like, what is this waveform? So this was a special weekend, man.
Yeah,
cool.
For sure. Okay, just another representation of the same waveform here. Right vertebral artery is not seen, or you're having a hard time. I definitely saw the process here. It's just, you're just having a really hard time there. Okay, subclavian, let's see what we get. And, oh man, delayed upstroke. Yeah, definitely an abnormal waveform. Nowhere near triphasic.
Can you go back?
Sure.
So, again, we have so many questions about in our SVU discussion channels and on the net about what is the ECA velocity criteria, what is our subclavian criteria, and we contacted actually the IAC, again, our accreditation panel, and we questioned, can you give us some guideline? What is the subclavian stenosis guideline? And they provided us that the 200 centimeter per second peak systole is the more than 50%. But here, when you do not have that high velocity, but based on a waveform, you have to call the stenosis.
Yes.
So I think this is where I think the art of our interpretation and a little bit about the masterclass, that you cannot always use a certain criteria of velocity, because you need to go more proximal to really find the increased velocity, because there definitely a stenosis from this signal. So this is our favorite line that you probably guys heard it all the time, that if that systolic upstroke is delayed, that between that measurement point and the heart, somewhere there's a blockage, there's a hemorrhagic significant disease. So this is why we just need to go more proximal when you see that abnormal waveform, because you definitely will find that increased velocity.
Mm-hmm. There was another point that I wanted to make with the, what was it, the volume flow?
Mm-hmm.
So some sonographers might say, oh, well, Dr. Garami, I mean, why can't you just go by the peak systole and the end diastole of both and see that there's a huge difference between the two? Why even mention, you know, like the volume flow? And the truth is that one waveform might be more high resistant than the other, but your end diastole is not going to really give you
Mm-hmm.
that much information, or like, well, the how you say it, the volume flow is going to change with resistance, right?
Mm-hmm.
So that's going to be your kicker for, like you said, whenever, if you had bilateral common or ICA disease,
Mm-hmm.
which one would you choose? Whichever one gives you the more, you know, blood
Mm-hmm.
flow is the one that you're going to avoid,
Mm-hmm.
because that's the one's going to
Mm-hmm.
provide you the
Yeah.
compensatory flow, right? Anyway, okay, so we're on subclavian monophasic waveforms, complete obliteration of the Doppler signals. We're going to the left. Here's a better view of that, yeah. So ICA here, ECA on the inside there.
The cysts in the thyroid.
Yeah, not really seeing it.
Those are just incidental findings.
Right.
We do not focus on that much.
I saw it, yeah, I see what you're saying. It's
Mhm.
like a parathyroid maybe. So definitely having a hard time seeing the bifurcation. But we're seeing some color and pulsatility, right?
Mm-hmm. Can you play it one more time?
Sure.
I just want to digest it. Can you point to CCN when the bifurcation happens?
Bifurcation right there.
So can you stop the
Right,
video
sure.
and scroll image frame by frame?
Frame by frame.
Oh, stop! See between right there. You see that whole right there?
Yeah.
There is definitely a lumen without color signal.
So here's the distal
Mhm.
CCA moving up, up. There should be the bifurcation here.
Yeah.
Yeah.
And that's not the thyroid cyst. So this is where you see that dark hole and a circle that definitely maybe.
Oops.
Yeah.
Sorry. Right here. Probably the best frame here. So your ECA,
Mhm.
I think I see it here. Okay.
Yep.
Smooth intimal lining. Doppler signals showing high resistance in the proximal CCA. 69.0.
Mm-hmm.
Mid still relatively smooth. 84.4. Maybe 0.
Mm-hmm.
Maybe some soft plaque here on the
Mhm.
or plaque. B flow, my favorite. Probably not in this case. Yep, definitely some plaque on the bottom side there. So we're grabbing some signals a little bit more proximal than the end of the distal here. 48.0. ECA, proximal ECA. So some hard plaque in the proximal segment here. Definitely seeing some aliasing and bruit. following it.
Mhm.
Could increase your scale just a tad, so you can kind of localize your highest velocity point within that particular segment. 355 over 10. 458, and an increased end diastole, 63 is what it's marked at.
So definitely we can discuss right away that our ECA criteria is just less or more than 50%, and our cutoff is 150.
150.
Yep. So definitely let's
go
guarantees a left ECA more than 50%.
Okay, here's the sweep of the ICA.
Oh,
If
and
anything's
can you point out the I call it the DEN sign, this longitudinal pulsation? Dan was teaching us that how you look at again the pulsatile of the artery, that this longitudinal pulsation may be a sign of something there. Okay, show me our fancy B-flow. What happened with the half of the screen? No.
Sometimes this machine gets wonky.
Yeah. I'll blame it on the machine. But what I wanted to see is I wanted to see that B-flow on the same image right there. It's too bad that you can just do side by side or even do an overlay of that B-flow right there.
I know. There's been a lot of times where I thought I could and I tried. So first Doppler signal, putting it inside the ICA, we're just not getting any Doppler signals whatsoever. Second time around, we have this on the sweep, we're seeing this focal aliasing point here that's showing color. So, taking a shot at it, we're getting 463 over 86. This could be moved down a little bit further to the end diastole.
Yeah, one of my fancy thing that I hate those numbers because they were the same number what we recorded in the ECA.
Exactly, right? You should be suspicious that this is actually cross-incination is the artifact.
Yep.
We're trying to follow the mid-ICA, and we're getting a lot of Bruy signal here. What you could do is increase your scale, and that'll eliminate a lot of the smaller signals.
Can you go back for a second on the very first when we didn't get the signal? One more.
Right here.
One more. Yeah. So here, what would be your trick? Would you open up your sample more? Definitely. Would you drop your scale? So what are the tricks in a moment you're not sampling something that you know that you're in the middle of the lumen and you're not getting any signal?
If we're suspecting a high grade stenosis, like we're talking about maybe 99%, really a higher scale would be your friend. Because when in cases where you have trickle flow, the velocities are extremely high.
So basically, in a low scale, you wouldn't see it because your end diastole would be over your scale. And what do you think about just 0 degree angle on a cross section? So if your question, hey, I want to know this is open or not, and do I see any flow? I think these are the troubleshooting things that what would you pull out as your next weapon to see the flow in the ICA?
That's brilliant. Yeah, so you can use physics as your friend. Instead of trying to descale, that's another way of descaling. It's the same concept as if you were using like a physiologic study. It's like, oh, my artery is just bounding off of the screen. It's like, well, what can I do? If you just change your angle to be more perpendicular, you can squeeze that Doppler signal down, and it's still maintaining the triphase waveform. So you're just simply reducing the Doppler shift with the straight box. Cool. Yeah, I like it. So looking at the trajectory, it's hard to see, but so far we're in the ICA.
Go back. So on this signal, again, as the interpretation, go back to the waveform.
Okay.
So here's what you are telling me with the label. I'm buying it because I did not see any branches. I did not see, by sizing, it looks to me an ICA size vessel. So again, by labels, by the waveforms, maybe a little bit too high resistance for an ICA. So those are the things that kicking when you go back and try to analyze everything. The next waveform, I think it's the same. Can you show me the distal ICA?
Sure.
So here's the same, as no branches, looks like a straight ICA vessel with a high resistance signal. So this is one of the things that I would ask, is this ICA is really open distally? So with that high resistance ICA signal, maybe an interpretation I would put in potential distal obstruction, maybe this is only feeding the eye. So maybe this ends up in ophthalmic. The peak systole is quite high just to be like a trickle of flow in an ICA, but definitely this is too high resistance to call it ICA.
Yeah, because even in high-grade stenosis with ICA, you would have a elevated
diastole. Yeah. The only thing is that if you would see that ICA, I just had another case today, everywhere was a high resistance doses, sometimes with the chronic hypertension, you're going to see that throughout every vessel going to have a high resistance signal, but that's a different case. You will need to see that every vessel will have that high resistance.
Mm-hmm. Oh yeah, that's true, because it's more central. It's like a heart issue, likely.
Very good. And your vert?
Antegrade vert.
Cool.
Yep. Wanted.
So let's see the subclavian and let's see what's our interpretation.
Triphasic.
Okay. And again, on the subclavian, our threshold is 200. This was under 200.
Just under.
But again, the waveform telling you that this is again a healthy looking subclavian versus you had a not that healthy looking subclavian on the right side. So that is again what happened, that based on that abnormal blunted waveform, I requested rescan. Rescanning the right bulb and the right subclavian more proximal. And this is again just a few hours later. You can continue and we'll see the additional scanning. This is again not being mean, just wanted to get the most information out of, again, of our carotid ultrasound, and on the top of that, sure, we'll have imaging correlation as well. Mm-hmm.
All right, just running through it, a little bit of a zoom.
And this is again just a gorgeous picture showing the plaque, and definitely this is our ECA, what we saw. And what I was missing that this color clip needs to go into the ICA. So this is where I wanted to see that color Doppler signal showing no aliasing in the ICA. And there's no aliasing. So this is again a stunning for me, that I definitely think that dramatic waveform change in the ICA then definitely just contributed by another proximal stenosis.
Mm-hmm.
We can go next. Again, the Cca waveform did not change after a few hours.
Yeah.
It's the same, I think, Egyptian pyramids.
Some sand dunes, Yeah, and actually walking the Doppler through, we get a very nice appreciation of the waveforms, little to no change. IJV showing that it's definitely not the vein, and the vein has venous signals.
Very good.
Okay, we're doing another mid-common carotid artery to get velocities to do the IC-CCA ratio to prove that there's probably no stenosis.
And then we went to subclavian in the innominate. So I think that was the other key element for the proper diagnosis. And you can see this tortuosity right there. You can see how the common goes up. And this is your subclavian doing the letter S. Very good.
Okay, still moving.
Beautiful.
Yeah, so...
And this is where, again, just when you see that abnormal waveform, go more proximal, because I think this is where became like a really complex case to show that the left side, normal subclavian, but the right side. And this is where you need to look at those two waveforms side by side to really convince you that definitely there's more disease proximal. Next.
Very good. A couple more. and aliasing just throughout. But yeah, you're seeing that monophasic, blunted.
But look at, go back, look at the velocity. So sorry, my glasses.
Yeah, it's a little high.
450 over 100. So this is definitely, we found that increased velocity. Second, that you still see the systolic upstroke. So I think that's another confirmation that in a moment you found that proximal stenosis, this is where your systolic upstroke present. If you go distal to that, you're going to lose it. You can see the blue, that's signal, that would be your subclavian going down. And that tortuosity going to give us a challenge also if you would like to definitely treat this disease coming up from the arm or coming up from the aorta. Those are the options. But the bottom of the color box give you a little clue too that you do have an open vessel. That's definitely getting antegrade flow into innominate vessel, because again, having a questionable innominate occlusion would change the option what we would do as surgery and what would be the treatment option. But definitely the imaging correlation definitely recommended here too. And last one is just one more measurement. Very good. Thank you, sir.
Yep.
So I would like to show you the images what we have on MRI and DSA. Can we switch to my computer, please? And what you're seeing here on the left side, you see the carotid. On the left side, you see the carotid, but I don't see bifurcation. You see a very strong left vertebral, and I do not see a right vertebral. So we did not see the right vertebral, so that's a not seen or occluded, but again, we just call it a not seen on our ultrasound, but here's a confirmation by MR that is occluded proximally at least. Very interesting that on the distal, on the tip of the basilar, we see an aneurysm, but here you see the distal part of the vertebral intracranial actually was open. And the MR also revealed that there's no flow in your left carotid system. So I think the left ICA occlusion is also confirmed by an angio. I will show you the angio first and I will come back to this picture. So this is your stump. So this is injection in the left common. This is your ECA, giving you the branches of the ECA. And it was stunning that on the ECA we didn't have too many branches, but because of the size almost similar to what your common was, this is why we mistakenly identify as this could be your ICA with the high resistance pattern, but your proximal ICA is definitely occluded.
Right.
And here's an angiogram of that tight lesion of the innominate artery, and again the tortuosity of the subclavian. I think what we are using again an MR, and actually what we will do is to try to rotate it that you will able to see these two vessel and here's your right vertebral. So this is a Dyna CT done on angio that you're doing a reconstruction of the vessel, planning your aneurysm exclusion probably with a flow divider, and this is where you see that the intracranial part of the vertebra is still open. So proximal we didn't see any flow, but that's what we have right there. And what I thought while you sharing your 2 days prior, I think you scanned the same patient arm, and I just want to see if you have anybody on Kahoot, and I want to start the game. I want to see if anybody is on with us. We are going to wait. If we have anybody online and would like to join us for a quick game. Actually, I need to wait for
the players to join.
Players.
They're already in earlier.
Did I see the game?
Yeah, I think so.
Oh, I need to generate. I'm so sorry.
Sorry, guys.
Sorry, guys. We have a new pin 611-8692. The new pin is 611-8692. We have about another 10 minutes to play. Meantime, can you open up the ARM study on the 113?
113.
So we'll see if we have anybody who wants to play with us.
It was a good crowd, about I think 70 something people.
Yeah, but there
But
was on our conference, so we had 76 people.
I see.
I guess nobody's online wants to play with me, so I am going to show you guys what we did. So these are the questions what we set up. That we showed you a carotid waveform, and the answers were: is this a 50 to 69, 70 to 99 occlusion, or none above? And a few of them selected no answer, and this was one of the eye-opening that why based on the velocity everybody went for the 50 to 69%, and only a very few people saw the occlusion, the extremely high resistance, no diastolic flow in ICA. We need to call it occluded. The second question, I have to say that these are again not easy. You see the stent, and outside the stent you see a little bit of flow, and then you see no flow inside the stent, just outside. So this is again not a hematoma, not instant stenosis, but the instant occlusion. And again, these are not easy cases, so we can definitely play this game some other time when we're advertising a little bit more. That was my other waveform. This was a left vertebral, really fancy, and this is one of those V-shaped cutout I've seen in systole. And basically, I would say very few people got it, saw the subclavian steel. Everybody wanted to see based on the velocity, hey, this is a normal vertebral because the velocity numbers are okay, quite low to be honest, but again, no stenosis. And intra-aortic balloon, some people thought that this is an intra-aortic balloon pump. So I'm extremely proud of those answers, how I really wanted to see how the people were thinking and what they see on these different waveforms. This image is a intracranial vertebral. Again, you need to recognize the V shape on this image, and the foramen magnum really hint towards the TIC. This is what you see on a TCD as a Thermon index cranium. I'm very sorry, I'm kind of trying to make it really not to show you normal or easy ones. So everybody thought that this was a vertebral artery and vein. So again, this is a beautiful, but both has a beautiful systole, and a vein should be more delayed. The vein would be probably a bump somewhere in the right before the aortic valve closure. But definitely, those people are in my training session who did not even dare to answer. So I think this is why it's kind of worth teaching with these waveforms. And when you look at how many wrong answers we get on these certain beautiful pictures, so here's my favorite TCD images. And when you have MCA labeled, this does not mean that this is an MCA signal, because the label, it tells you something, but the signal is a blue and going away from your probe on both sides. So these are bilateral ACA signals. So why they cannot be vertebral? Because then you wouldn't see this much red at the depth of 50, and I think the 50 red tells you that those are the MCA. So together with the MCA signal, only the ACA you can see. You cannot see the PCA, you cannot see the vertebral. So the two really good answer was MCA, ACA, and definitely the ACA is the winner on that one.
Yeah, the sampled segment.
And again, when you're looking at out of the 79 players, how many really go into the wrong direction, I think this is giving us encouragement that I think we still need to go back and do more education and more TCD classes. And I'm sure that from January when we regroup, we're going to have more TCD classes for sure. This is an easy one because you see it on M mode that it's a multiple depth at the same time. So this is a not traveling. On a spectrum, it's sitting on a zero line, and it's a bidirectional signal. That's the no for the embolus. So this is definitely not an embolus. This could be a tapping. This is not an embolus in MCA or a vertebral. So blue could be a vertebral or it could be a basilar. but definitely it was the tapping. So this was just one of those things that you need to differentiate. What is the true moving embolus and what's the not moving emboli? Okay, here is a beautiful Cca waveform. And this is the first time that I felt hope that we have lots of correct answers for the significant ICA disease. And I think today in a master class, we kind of demonstrated a similar idea that in a moment you see that increased high resistance in the Cca, you really need to think about further down on that disease for sure.
Right, so this is kind of like the opposite. We're looking at, or today we were looking more at proximal stenosis, whereas in that particular image we're looking at distal stenosis.
Yes, and
Yeah,
I think the velocity wise, so I think here's the velocity wise 58/11, so that's again by the decreased flow you will pinpoint that as well. Here's another good one. I always happy that when I see so many bad answers and how many, so the game was that when you the machine is also timing how fast you put your correct answer in as well. So I checked on you, you had about 3 that you didn't even answer, so this is another beautiful report that we can go back and test it again. But I think this was the other beautiful signal that I wanted to see, that how the people will believe that this is a subclavian steel or maybe just a vertebral vein. Again, how the variation and again the color signal, I chopped it off here, but kind of give you a clue that this is maybe a venous signal instead of arterial signal.
Yeah, that one was really tricky.
I'm so sorry. Here's another tricky one. I always see there's so many bad one. So someone thought that this is a 4D. 4D would be definitely moving too. So with a 3D not moving, cannot call it 4D. So the 4th dimension, you will need to move that flow. And if this start pulsating, then we'll get the 4D for sure. And with my Hungarian joke, this is why they call it a cubic cube. Just too proud to that Hungarian toy that is still, making me think that this is one of those ugly cubes that we are trying to work on those 3D. And I think it's not there yet, but when you want to demonstrate a beautiful stent or beautiful flow, I think we need to just improve our 3D capabilities for sure. Just a few more because we are almost out of time. So here's an easy one. So we had purposely selected an end-diastolic velocity over 140, and again this way you had to really pick the 80 to 99, and we had a majority of our answers were correct. So when your end-diastolic velocity goes over 140, definitely that's the key element, that it's more than 70%, and we call it for mainly for the asymptomatic carotid disease, a tighter group of the disease range between, and the stenosis between 80 to 99% on that one.
Right, 50 to 75% is going to be immediately ruled out because that's actually part of your arterial thresholds.
Okay, I think Kahoot is dead on me, so I have no choice, but I would like to thank everybody for joining us. And what I wanted to share is that next month we'll have Dr. Peden talking about AVF. So the Air Force is the Top Gun challenge, but I think the AVF protocol, and we still need to learn about how we can improve our AVF ultrasound protocols, and Dr. Peden is going to teach us. And again, I just want to thank you for joining us today, and see you next month. So we're not saying goodbye for the entire year yet. We're going to have one more monthly session on December 15. But thank you so much for tuning us and watching our cases.